Welcome back to the deep dive. Today, we're tackling a subject that, well, it often comes with a lot of anxiety. We're talking about the breast. And usually when breast issues come up, the mind immediately jumps to the big C, to cancer.
That's right. The fear is palpable.
But today, we want to move beyond that immediate fear. We're going to dig into the really wide, sometimes confusing range of common, totally normal, and, importantly, non-cancerous changes that happen in breast tissue.
Yeah, and it's crucial because the scale here is huge. Our sources, like SCHWARTZ's Principles of Surgery, point out that maybe up to half of all women in the U.S. will see a surgeon about a breast issue at some point.
Half. Wow.
Yeah, and about a quarter of those women end up having a biopsy.
Okay.
But here's the key statistic, the one that drives our discussion today. The vast majority of those biopsies, maybe 70%, maybe even more, show something completely benign.
So that's our mission then, to sort of cut through the dense surgical text and give you a clear picture of how doctors classify these common benign things, what the actual risks are, because they really do vary and are managed today. We're mapping out that whole territory between just normal variations and actual disease.
Exactly, and you can't really understand these benign conditions without grasping a core idea. The breast is an incredibly dynamic organ. It's constantly changing.
Right.
These benign disorders aren't just random events. They are deeply tied to the normal hormonal rhythms of a woman's reproductive life, and then later to the involution phase, the natural winding down process.
So understanding the cycle is key to understanding the condition.
Precisely. If you get the cycle, the disorders make much more sense.
And those cycles are driven by hormones, primarily estrogen, progesterone, and prolactin, right?
Yeah, absolutely. Those are the main conductors of the orchestra, dictating growth, function, change. When everything's in sync, development is normal. But when there's a slight mismatch, maybe the growth phase is a bit off, or the breakdown, the involution, isn't perfectly coordinated. That little aberration is what often shows up clinically as a lump or pain or maybe some discharge.
Okay, so let's talk about this idea of aberration versus normal. The sources introduce a really helpful way to think about this called the ANDI classification. Aberrations of normal development and involution.
ANDI. It's a fundamental shift in thinking.
Yeah, it moves away from seeing every little change as some isolated disease.
Exactly. ANDI is foundational because it organizes things logically. Think of it like a grid. Horizontally, you've got a spectrum. Normal variations, then disorders, which are mild abnormalities needing maybe just reassurance, and then disease, which is more severe, needing actual treatment.
Okay, normal, disorder, disease, like a gradient.
Right, and then vertically, it lines these up by the patient's age or reproductive stage. Because what's common or normal really depends on whether someone is, say, 20 or 50.
That structure seems incredibly useful for clinicians. It gives you an immediate map.
It does.
If something falls into normal for that age group, you don't need years of anxious follow-up.
Precisely. It helps manage that anxiety. It frames it as, look, this isn't some disease you've caught. It's a predictable variation in how your breast tissue behaves at this stage of life.
Let's walk through that life path then, starting with the early reproductive years. ANDI puts this roughly between ages 15 and 25. Growth is the main theme here. What kind of things pop up?
This is really the prime time for fibroadenomas. They're the most common benign tumors, and they're a perfect example of ANDI in action.
Okay, fibroadenomas, what are they exactly?
They're well-defined lumps, usually feel quite firm and rubbery, and importantly, they're mobile. They move around easily under the fingers. Histologically, they're made of both the glandular tissue and the supportive connective tissue, the stroma.
And they usually show up as a lump someone feels in this younger age group.
Predominantly, yes. That's when they're most often symptomatic or discovered.
And even these common lumps exist on that ANDI spectrum, normal to disorder to disease.
Absolutely. A tiny fibroadenoma, say, under a centimeter, that's often considered just a normal blip in lobular development. Many women have them and never know.
Okay.
If it gets a bit bigger, maybe up to 3 centimeters, it crosses into the disorder category. Still benign, but noticeable.
Right.
But then if it becomes really large, what we call a giant fibroadenoma over 3 centimeters, or if a woman has several of them, maybe more than 5 in one breast, multiple fibroadenomas, then that's classified as disease. It needs active management.
And you mentioned the hormonal connection earlier. That seems really clear with fibroadenoma.
Oh, definitely. They're not static. They can grow, sometimes quite rapidly during pregnancy because of the hormone surge. They can even lactate.
Wow.
And then after menopause, when hormone levels drop, they often shrink or disappear completely. They're tied right into the body's hormonal system.
The ANDI framework also mentions nipple development issues in this early stage, like nipple inversion.
Yes. If nipple inversion has been present since puberty, it's usually classified as a developmental disorder. It often happens because the main milk ducts underneath are just a bit too short or maybe slightly obstructed, pulling the nipple inward.
It's not dangerous in itself, but it can lead to problems later.
That's the key. That inversion can hinder proper drainage from the ducts. This sets the stage for potential chronic infections down the line.
Ah, okay. So that's the progression to disease.
Exactly. If that underlying issue leads to recurrent subareolar abscesses, repeated infections under the nipple, or a mammary duct fistula, which is like a chronic tunnel connecting an infected duct to the skin, that becomes a disease state under ANDI, because it typically needs surgery to fix the underlying duct problem.
Okay, moving along the timeline. Next up are the later reproductive years, maybe ages 25 to 40. Here, the focus shifts to cyclical changes. Most women feel some breast discomfort with their cycle, but when does that cross the line in ANDI terms?
This is a really common question, and ANDI helps clarify it. Some cyclical breast pain or mastalgia, and that feeling of general lumpiness or nodularity before a period that's physiological. It's normal. It's the breast tissue responding to hormonal shifts, retaining fluid.
So what's the threshold for it becoming a disorder?
It's about persistence and impact. If that painful nodularity hangs around for more than just a few days, specifically more than 1 week of the menstrual cycle, it's classified as a disorder. It's moved beyond the typical premenstrual phase.
And when does it escalate to disease?
When the pain becomes genuinely incapacitating. We're not talking about mild tenderness here. This is pain that interferes with daily life, sleep, work, intimacy. That level of severity justifies the disease classification because it warrants more active treatment.
What kind of treatments?
It often starts with supportive measures like well-fitting bras, maybe dietary changes like reducing caffeine, and can escalate to medications, sometimes hormonal, sometimes not, to manage the pain. The defining factor is that significant impact on quality of life.
Now, there's a term that seems to cause endless confusion: fibrocystic disease or fibrocystic changes. Our sources seem to really dislike this term. Why is it so problematic?
Oh, it's a big one. Fibrocystic disease is incredibly vague. It's been used for decades as a catch-all for almost any lumpy or painful breast finding that isn't cancer.
Right.
Think of all the old synonyms. Cystic mastopathy, chronic cystic disease.
Right.
It just lumps everything together. And that's unhelpful, frankly, because it tells the patient and the clinician nothing specific about what's actually going on pathologically or what the risk is.
So if it's so vague, what's the recommended approach now?
The recommendation is clear. Diagnose and manage based on the specific underlying finding. If it's cysts, call them macrocysts. If it's overgrowth of cells, call it hyperplasia. You need that histological precision. Using the vague fibrocystic label should really be avoided because it prevents proper risk assessment, which we'll definitely get into.
Okay, makes sense. Let's move to the last phase in ANDI, involution. This is roughly ages 35 to 55. The breast is starting its natural aging, winding down, and this is cyst territory, right?
Yes, specifically macrocysts, the larger, often palpable ones. And their formation is a fascinating example of that uncoordinated involution we mentioned.
Yeah, so
Think of it like this. The supportive connective tissue, the stroma, starts to shrink and break down. But sometimes it does this faster than the actual milk-producing units, the lobules and alveoli.
okay.
So these leftover lobular bits might still secrete a little fluid, but the surrounding structure isn't there to support or drain it properly. They dilate, fill up, merge together, and boom, you get a macrocyst.
So it's literally the structure aging out of sync. Are these simple cysts usually a big deal clinically?
Mostly no. They're incredibly common. Many are found incidentally on mammograms and cause no symptoms. Simple macrocysts generally don't need any treatment unless they become large and uncomfortable or painful.
And then aspiration is the way to go.
Often, yes. If they're symptomatic, aspiration can provide relief and confirm it's just fluid.
Involution is also linked to some inflammatory conditions like duct ectasia.
That's right. Duct ectasia means the major ducts right under the nipple become dilated, widened. This often leads to nipple discharge, which can be thick and sometimes greenish or blackish. It's closely related to periductal mastitis, which is inflammation around those ducts.
The sources mentioned a bit of a chicken and egg situation regarding the cause.
Yeah, there are two main theories. One is that the ducts dilate first, ectasia, maybe just due to aging. This causes secretions to pool and stagnate, leading to irritation and inflammation, mastitis.
Okay.
The other theory flips it. Inflammation happens first, periductal mastitis, perhaps triggered by smoking or a low-grade infection. This inflammation weakens the duct wall, causing it to dilate secondarily, ectasia.
Does it matter which comes first in terms of outcome?
Clinically, maybe not directly, but the end result is often the same. Chronic inflammation can lead to scarring or periductal fibrosis. This scarring can then pull on the nipple structure from underneath.
Leading to nipple retraction.
Exactly. Permanent nipple retraction, if it develops newly in this age group, is considered a common involutional disorder under ANDI. It's a physical sign of these underlying ductal changes and aging. Understanding this helps distinguish it from more worrying causes of recent nipple retraction.
Okay, so we've mapped out the spectrum of normal changes with ANDI. Now we need to make a critical shift. We have to talk pathology, because telling the difference between these common benign things and the ones that might actually increase cancer risk, that's absolutely vital, isn't it?
It's arguably the most crucial step. We move from the broad ANDI framework to the specifics under the microscope, the histology. And for risk stratification, the system developed by Dr. David Page is key.
Right.
He grouped benign conditions into three main categories based on cell behavior: non-proliferative disorders, proliferative disorders without atypia, and proliferative disorders with atypia.
So the goal here is figuring out who needs closer watching or intervention and who can be reassured their risk isn't increased.
That's exactly it. It's about tailoring surveillance. You don't want to overscreen someone with baseline risk, but you absolutely cannot afford to miss something that significantly elevates their future risk.
Let's start with the biggest group, non-proliferative disorders. What's the risk here?
This is the good news category. These conditions make up about 70% of all benign biopsies. And the critical point is, they carry no increased risk for developing breast cancer later on. The relative risk is 1.0, basically the same as the general population.
So what kinds of things fall into this safe, non-proliferative bucket?
A lot of what we've already discussed based on ANDI: simple cysts, duct ectasia, periductal mastitis, mild hyperplasia that doesn't meet proliferative criteria, and importantly, fibroadenomas. As long as the biopsy confirms there's no atypia within them or in the surrounding tissue, it's essentially normal structure or minimal non-growing changes.
What about calcifications? They show up on mammograms all the time and can cause a lot of anxiety.
Right, and it's important to differentiate. Most calcifications seen on mammograms are benign. They're just tiny deposits of calcium resulting from old injury, secretions drying up, normal cellular debris, things like that. These tend to be larger, coarser, maybe round or scattered.
Okay.
The ones that raise concern are microcalcifications. These are tiny, often less than half a millimeter. And it's their pattern that's suspicious. If they look fine, linear, maybe like crushed stones, or if they appear in branching patterns that seem to follow the duct lines, that's a red flag.
Why that pattern specifically?
Because it suggests the calcifications are forming within the ducts, potentially outlining an area of abnormal cell growth like ductal carcinoma in situ or DCIS, which is a non-invasive form of cancer. Benign calcifications usually don't follow those architectural lines.
Got it. So pattern is key. Now, moving up the risk ladder. Proliferative disorders without atypia. Proliferative means cells are multiplying, growing more than usual. But without atypia means the cells themselves don't look cancerous yet. What's the risk increase here?
This group signifies a bit more cellular activity, so the risk does bump up slightly. The sources consistently place the relative risk for these lesions at about 1.5 to 2 times the general population's risk. It's a mild increase, but it's statistically significant.
What's a common example in this category?
One of the most frequent findings is florid ductal epithelial hyperplasia. Florid just means it's abundant. You see the epithelial cells lining the ducts, multiplying quite actively, maybe filling up a good portion of the duct space. It's found in maybe 20% or more of benign biopsies. It's common, but that specific level of proliferation is enough to nudge the risk up slightly.
What about papillomas? We mentioned intraductal papillomas can cause nipple discharge. How do they fit in risk-wise?
A solitary intraductal papilloma, the kind typically found in a large duct near the nipple causing discharge, is generally considered proliferative. But if it lacks atypia, it doesn't usually carry a significantly increased cancer risk on its own.
Okay.
The situation changes, though, if we find multiple papillomas, often located deeper in the breast tissue, in younger women. These multiple papillomas, or papillomatosis, have a higher tendency for malignant transformation and are watched more closely. They carry a higher risk.
This category also includes some tricky conditions, the ones often called cancer mimics, right? Like sclerosing lesions.
Yes, these are the real challenges diagnostically. Sclerosing adenosis is a classic example. Here, you have overgrowth of the small glandular units, adenosis, combined with hardening or scarring, sclerosis. The problem is, this process can distort the tissue architecture.
How does that mimic cancer?
It can create a firm lump on examination, and on mammography, the scarring can pull the tissue inwards, creating spiculated margins, those jagged star-like edges that look very much like invasive cancer.
So it looks bad on the film, even if it's benign.
Exactly. Leads to a lot of biopsies.
Yeah.
And then there are radial scars, or complex sclerosing lesions. These are even more concerning radiographically. They have a central scar-like core with ducts and lobules radiating outwards, often looking almost identical to a small tubular carcinoma.
That sounds incredibly difficult to sort out.
It is. The sources emphasize that distinguishing a radial scar from cancer based only on a core needle biopsy can be unreliable. The imaging is often so suspicious.
So even with a benign core biopsy result for a radial scar, you can't just stop there.
Often, no. Because the imaging looks so worrying, surgical excision is frequently recommended just to be absolutely certain there isn't a small cancer hiding within or nearby that the needle missed.
Okay, that clarifies the mild risk category. Now for the final and most significant group in terms of risk, atypical proliferative diseases.
Right. These are the lesions that are definitely abnormal. They share some, but not all, of the features of carcinoma in situ. They're sort of borderline, sitting right on the edge of being cancer, but haven't quite crossed the line.
And the main players here are ADH and ALH.
Correct. Atypical ductal hyperplasia, ADH, and atypical lobular hyperplasia, ALH.
And the risk jump here is substantial.
It's significant. This is where we see that fourfold increase in lifetime breast cancer risk compared to the general population.
Right.
Finding ADH or ALH fundamentally changes how we manage the patient's future risk.
Let's focus on ADH. It sounds like it's very close to early-stage cancer.
It is, histologically. ADH looks very similar under the microscope to low-grade ductal carcinoma in situ, DCIS, which is stage 0 breast cancer. The main difference, often, is simply the extent of the abnormal cells.
Size matters here.
Critically, if the area of these atypical cells is small, typically defined as involving only 1 or 2 duct spaces or measuring less than 2 or 3 millimeters across, it's called ADH. If it's more extensive than that, it meets the criteria for DCIS.
But a core needle biopsy only takes a tiny sample. How can you be sure you didn't just sample the small ADH part and miss a larger area of DCIS right next to it?
That's the crux of the management dilemma. There's a real risk of undersampling, of mistaking DCIS for ADH based on a limited core biopsy.
So what's the standard approach when ADH is found on a core biopsy?
Because of that risk of finding something worse, the standard recommendation is typically an excisional biopsy. That means surgically removing the entire area where the ADH was found, along with a small margin of surrounding tissue. This allows the pathologist to examine a whole lesion and be certain whether it's truly just ADH or if there's associated DCIS that needs different treatment. A diagnosis of ADH or ALH mandates a serious conversation about risk and surveillance.
Okay, let's shift gears to management. We know the diagnosis, we understand the risk level. How are these common benign conditions actually handled in practice today? Let's start with something really common, like a simple cyst.
For a palpable cyst, the classic approach is aspiration. It's both diagnostic, confirming it's fluid-filled, and often therapeutic, relieving the pressure and discomfort.
How's that typically?
Usually right in the office. The clinician stabilizes the lump with one hand and inserts a fine needle, maybe a 21 gauge, with the other hand to draw out the fluid.
And what happens with the fluid? Do you always send it for testing?
Good question. The standard protocol, driven by cost-effectiveness and yield, is that if the fluid isn't bloody, if it's clear, yellow, straw-colored, maybe even greenish or dark, you aspirate it completely until the lump disappears. And then you typically discard the fluid.
Why discard it? Seems counterintuitive.
Because studies have shown that sending non-bloody cyst fluid for cytology very, very rarely finds cancer cells. It's just not a high-yield test in that scenario. The crucial step is what happens after aspiration. The clinician must carefully repalpate the area.
To make sure the lump is completely gone.
Exactly, to ensure there's no residual solid mass left behind. If there is, that needs further investigation, possibly imaging or biopsy, because it could indicate an underlying solid component or even an intracystic tumor.
So bloody fluid is the main trigger for sending it off?
Bloody fluid definitely gets sent for analysis, and nowadays, many aspirations are done under ultrasound guidance anyway.
Why use ultrasound if you can feel it?
Ultrasound confirms it's truly a simple cyst. Thin wall, no solid parts, ensures you're targeting the right spot, and confirms complete drainage. It adds a layer of certainty.
Okay. What about fibroadenomas? You mentioned they're common in younger women and often self-limiting. Has the management become more conservative?
Definitely. Especially for younger women, say under 25, where the background risk of cancer is extremely low. If a lump feels like a classic fibroadenoma, smooth, mobile, and ultrasound confirms those typical benign features, observation is often perfectly reasonable. Many just stay the same or even shrink over time.
But if you need a diagnosis or if it needs to come out,
If a definitive diagnosis is needed, ultrasound-guided core needle biopsy is the standard. It's highly accurate. And if removal is necessary, maybe because it's growing, causing symptoms, or the patient prefers it, we now have minimally invasive options beyond traditional surgery.
what kind of options?
Well, for smaller fibroadenomas, typically under 3 centimeters, things like cryoablation are available. This uses extreme cold delivered through a probe to freeze and destroy the tumor tissue.
Freezing it away, essentially.
Right. Another option is using a vacuum-assisted biopsy, VAB device, not just for diagnosis, but therapeutically.
How does VAB work as a treatment?
The VOB device uses suction to pull the fibroadenoma tissue into a cutting chamber, removing it piece by piece through a very small incision. For lesions up to about 3 centimeters, it can often remove the entire thing, effectively treating it without open surgery. Much less scarring, quicker recovery. Larger ones might still need surgical excision.
Now, let's go back to those tricky cancer mimics, sclerosing adenosis, radial scars. You said the imaging looks suspicious, but the core biopsy might come back benign. How do you resolve that contradiction, that discordance?
This is a critical concept, radiographic pathologic discordance. If the imaging looks highly suspicious for cancer, but the core biopsy result is benign, you cannot simply accept the benign result and stop.
Why not? The biopsy is tissue, isn't it?
It is, but it's a sample. The core needle might have missed the worrisome area. The rule is, in cases of discordance, the suspicious imaging finding takes precedence. It raises a strong red flag that the biopsy might not represent the true nature of the lesion.
So what's the next step?
You need more tissue. This usually means recommending a larger biopsy, either a more extensive vacuum-assisted biopsy to sample the area more thoroughly, or, more commonly, an open surgical excision to remove the entire suspicious area for definitive analysis. You have to resolve the discordance.
Okay, that makes sense. Let's talk about nipple discharge. It's common, but when should it really worry someone? What are the red flags?
Nipple discharge needs careful evaluation. The characteristics that make it suspicious, warranting a workup, are if it's spontaneous, happens without squeezing, unilateral from just one breast, seem to come from a single Dutch opening, is bloody or blood-tinged, serosanguineous, or if it's associated with a palpable mass, especially if these occur in women over 40.
Any of those flags means investigate further.
Yes. That usually involves diagnostic mammography, targeted ultrasound, potentially ductography, injecting dye into the duct, and often surgical excision of the involved duct system to find the cause, which could be a papilloma or, less commonly, a cancer.
And when is discharge generally considered benign?
It's more likely benign if it's bilateral, comes from multiple ducts when the nipple is squeezed, and the fluid is milky or colored, like green, yellow, brownish, often seen with duct ectasia. Milky discharge, especially if bilateral, might prompt a check of prolactin levels to rule out hormonal causes. If it's non-bloody, multiductal, and especially in younger women, say under 40, it's usually physiological or related to benign duct changes.
Okay. Lastly, there's a condition called Mondor's disease. Sounds a bit dramatic. What is it?
Mondor's disease is quite distinct. It's thrombophlebitis, basically inflammation and clotting of a superficial vein in the breast or chest wall. People sometimes call it string phlebitis.
What does it look and feel like?
The patient typically presents with sudden onset of pain in a specific line on the breast or upper abdomen, and you can often feel and sometimes even see a tender, firm cord just under the skin. It follows the path of the affected vein, like the lateral thoracic vein.
But that sounds like it would be alarming to find.
It can be. But the most important thing to know about Mondor's disease is that it's almost always completely benign and self-limited.
Meaning it goes away on its own.
Exactly. It typically resolves within about 4 to 6 weeks without any specific treatment other than maybe warm compresses and anti-inflammatory medication like ibuprofen for the discomfort. Biopsy is rarely needed unless the diagnosis is really unclear or if there's a suspicious lump right near the cord. Mostly, it's about reassurance. #outro.
So wrapping this up, we've really covered a lot of ground today. We've tried to give you that framework, the ANDI classification, to understand how the 9 breast conditions fit into the normal life cycle. Normal, disorder, disease, and how they relate to different stages of life. Then we dove into the pathology, sorting conditions by their potential risk. The vast majority carrying no increased risk, a smaller group with a mild 1.5 to 2-fold risk, and that critical category of atypical lesions ADH and ALH carrying that significant 4-fold risk.
Right. And hopefully the key takeaway for you listening is that while breast changes are incredibly common, understanding the specific diagnosis is what matters. Most changes are part of normal cycles or involution.
Knowing if it's a simple cyst versus, say, atypical hyperplasia dictates everything that follows.
Exactly. It determines whether the right path is just observation or maybe a minimally invasive treatment like VAB for a fibroadenoma, or if surgical excision and much closer follow-up, even risk reduction strategies, are needed. That precision is the antidote to that generalized anxiety.
And let's circle back to that high-risk group, the atypical proliferative diseases like ADH and ALH with that 4-fold risk. That number really sticks with you.
It does. And that leads us to a final thought, something really important to consider about how we use this information. When a pathologist identifies one of these high-risk benign lesions like ADH or ALH, that diagnosis isn't just labeling something that's already there.
It's more than just a label.
It's a trigger.
Yeah.
It becomes a critical tool for actively managing that patient's future health trajectory.
So paradoxically, getting that scary benign diagnosis might actually be a crucial opportunity.
Precisely. Because identifying that 4-fold increased risk requires us really to initiate aggressive risk reduction strategies. We're talking about things like offering chemoprevention.
Like tamoxifen.
Exactly. Drugs like tamoxifen or raloxifene or aromatase inhibitors in postmenopausal women have been clearly shown in major trials to significantly reduce the incidence of future breast cancers, especially estrogen receptor-positive cancers, in women identified as high risk based on these very findings. So classifying that benign lesion correctly isn't just about closing the book on the current finding. It's about opening a new chapter focused on proactive prevention, fundamentally changing that individual's long-term outlook. It turns risk into an opportunity for intervention.